Good morning to all. I will be starting with my topic, effect of sarcopenia on overall survival in patient with cirrhosis. So I will be covering this topic under sarcopenia and frailty, diagnostic criteria, pathogenesis, mild sarcopenia, sarcopenia post-liver transplant, ILB's data and future directions. Sarcopenia is a physical state defined by loss of functional skeletal mass, and frailty is characterized by decreased physiological reserve and increasing vulnerability to health stressor. The prevalence of sarcopenia and frailty in cirrhosis ranges from 40 to 70%, and while frailty is 18 to 43%. There is a considerable overlap of sarcopenia and frailty in view of etiology, pathogenesis, management, like aging, muscle wasting, inactivity, socioeconomic status, and recurrent hospitalization, endocrine dysfunction, refractory ascites, hepatic encephalopathy, and comorbidities, decreased oral intake, all leads to sarcopenia and thereby can lead to frailty with decreased reserve. We can test for frailty and sarcopenia under frailty index, clinical frailty scale, hospital frailty score, and physical frailty in the form of liver frailty index, short performance battery test, adjusted daily living, Karnofsky physical score, 6-minute walk test, gait speed, and sarcopenia under CT MRI based muscle mass, DEXA, thigh ultrasound, and bioelectrical impedance analysis. Some diagnostic criteria for sarcopenia are like from European group and ESPN group. They diagnose at low muscle strength with grip strength of 27 kg in males and less than 16 kg in females with using non-dominant hand. Low skeletal muscle mass in terms of appendicular skeletal per height, 7 kg in males and 5.5 kg in females with 2 standard deviation. For diagnosis of severe sarcopenia, low muscle performance while with gait speed of less than 0.8 meter per second or short performance battery test of less than equal to 8. All of other headings also cover more or less the same definitions with minor changes. If we look at the pathogenesis of sarcopenia, it starts from the oral intake, role of hormone and cytokine, sympathetic nervous system stimulation. So decreased oral intake in cirrhotic with ascites patient can be due to anorexia, early satiety due to ascites, hepatic encephalopathy, bacterial overgrowth, decreased bile flow, pancreatic insufficiency associated with alcoholic hepatitis patients with cirrhotic. Hepatocyte dysfunction can deplete glycogen store that thereby leading to gluconeogenesis and depletion of and utilization of essential amino acids and depletion of alpha ketoglutarate. There is a role of vitamin hormones also, like vitamin D. It stimulates follistatin and decreases and inhibits myostatin, and IGF-1 by the stimulation of testosterone stimulates protein synthesis. Hormonal imbalance like leptin, ghrelin also changes the appetite and the muscle status. Insulin resistance also play a part with the AKT and mTOR pathway. mTOR pathway is helpful in protein synthesis. Cytokine in the form of inflammation. All inflammation causes decreased stimulation of cytokines and decreases appetite and thereby causing sarcopenia. Sympathetic, as cirrhosis is a hypermetabolic state, and there is a sympathetic nervous system hyperstimulation causing higher resting energy expenditure and leads to sarcopenia. So this is a citric acid cycle where we see acetylcoenzyme enters into the citric acid cycle and alpha ketoglutarate, which is essential, and it gets utilized by the ammonia to form glutamate and glutamine, and the alpha ketoglutarate level decreases and the ATP energy production decreases and the energy meds are not met and sarcopenia can thereby occur. If we go into pathogenesis, then like this in this diagram, the protein synthesis requires branch in amino acids, testosterone level, which with help of mTOR pathway it causes protein synthesis. Insulin and IGF-1 also stimulates the mTOR pathway and helping in protein synthesis. Well, vitamin D with the help of follistatin, and IGF-1 also stimulates the follistatin. It stimulates mTOR pathway and help in protein synthesis. Well, ammonia with the help stimulates NF-κ beta inflammatory cytokines and pathway, and stimulates myostatin. Myostatin causes protein degradation, and follistatin inhibits myostatin, thereby helping in protein synthesis. So myostatin basically bad, and follistatin stimulates the protein synthesis. Due to gluconeogenesis and utilization of essential amino acids, protein synthesis gets disrupted, and there is a degradation of the proteins and essential amino acids. So coming to my topic, which is sarcopenia and survival. So this article with the title of Prognostic Value of Sarcopenia in Patients with Liver Cirrhosis. It is a systematic review and meta-analysis. It included 20 studies, and 2 studies utilized bioelectrical impedance analysis, 10 studies used cross-sectional muscle area, and 8 studies used total psoas muscle area. And it shows prevalence of sarcopenia among participants were 48.1%. Men were more affected with 61%, and women were 36%. There was a 15% changes of Asian patients population were affected more than the Western population. So Asian population had more sarcopenia as compared to the Western. Impact of sarcopenia on mortality. As we see, this hazard ratio is less than 1. It shows that hazard ratio of mortality with muscle mass. As the muscle mass decreases, the mortality increases. As the muscle mass goes up, the mortality will decrease. And this forest plot shows hazard ratio of complication occurrence such as sepsis and severe infection to sarcopenia. And it shows hazard ratio of severe infection to muscle mass was 0.53. As the sarcopenia increases, the risk of infection and sepsis increases. Sarcopenia is also directly correlated with the longer hospital stay and risk of infections. Whether MELD correlate with the sarcopenia. So there is a MELD sarcopenia study which showed they included 69 cirrhotic patients who were, and skeletal muscle mass were measured at L3 level, and they showed the patient who had sarcopenia, they had poorer survival as compared to those who did not have sarcopenia. And factors associated with mortality included ascites, albumin, low sodium, sarcopenia, and MELD score. When they did subgroup analysis, they found that patient with low MELD versus high MELD, the patient with low MELD had more impact with sarcopenia as compared to the high MELD. And as we see, MELD sarcopenia, the 3-month mortality was 0.85, 0.73, and 0.7. It is higher than the only MELD and MELD with L3 skeletal muscle index at 3 months, 6 months, 1 year, and overall. Whereas if we include patient with MELD more than 15 and sarcopenia, then there was a comparable, or rather it was decreased than the MELD with skeletal muscle index or only MELD. So overall, MELD with sarcopenia performed better, with predicting 3 months, 6 months, 1 year, and overall mortality of 0.73. So another one study, impact of sarcopenia on prognostic value of cirrhosis, and they also showed those patients who had MELD less than 15, CTP class A and B, and non-clinically significant portal hypertension and clinically significant portal hypertension, in their sarcopenia performed better rather than the patients who had higher grade of decompensation, and they had included severe portal hypertension with HEPG of more than 20, and they found that MELD, higher portal hypertension, HEPG more than 20, and sarcopenia did not predict survival as compared to clinically significant portal hypertension and lower grade of liver failure. This forest plot also shows that MELD less than 15 and no non-sarcopenia had higher prediction of prognostic value in severity of cirrhosis, and also HEPG 6 to 9 with non-sarcopenia and sarcopenia, they performed better rather than higher HEPG and sarcopenia. Whether testosterone level testosterone impacts sarcopenia or not. So this was a only studies in 2015. It was a 12-month double-blind placebo-controlled trial of intramuscular testosterone in 101 patients and with established cirrhosis, and they have given 1000 testosterone undeconate to these patients, and they showed that patient who received testosterone, they gained the appendicular lean muscle mass as compared to those patients who did not receive testosterone. And this table also shows that patients who had received testosterone, there was an increase in lean muscle mass, appendicular lean mass, and the decrease in total fat mass. Also, change of parameters from baseline to end of trial also shows that there is those group who has received testosterone, there is a better appendicular lean mass, decreased fat mass, and bone mass also was improved. This thesis was from our institute, Dr. Sushru thesis. He did addition of testosterone therapy to nutritional and structural exercise next, and without testosterone, and he had enrolled 202 patients, and primary endpoint was increase in appendicular lean mass by 10% at 6 months. He found that significantly more patients achieved primary endpoint in those patients who received testosterone as compared to those who did not. There was 66% gain of primary endpoint, which was a appendicular lean mass index improvement. Patient in next group, that means those who received testosterone, had a better hand grip strength, 6-minute walk test, lower TNF alpha level, and a lower serum ammonia level. And 38% in the testosterone group also had improvement in frailty category. And during the 6 months follow-up, hospitalization was also required by less number of patients in testosterone therapy rather than those patients who did not receive testosterone. So whether muscle depletion increases the risk of overt and hepatic encephalopathy. Muscle depletion and encephalopathy go side by side, and there is due to inability of urea handling in the liver, the muscle also gets to play a role, and the glutamine synthesis and glutamate levels are usually first metabolized by the liver, which is failing, so muscle gets metabolism, and as they metabolize, the alpha ketoglutarate level decreases, and there is a sarcopenia occurs in these groups. So whether alcohol causes sarcopenia, and it is seen that alcohol causes mitochondrial dysfunction with the impact on electron transport chain, ATP production, and it leads to sarcopenia and decreased muscle mass in alcohol-related liver disease. Also, skeletal muscle hyperammonemia causes muscle atrophy, and as I told, there is a loss of tricarboxylic acid cycle intermediate, that is called catapleurisis, and there is a skeletal muscle gets more handling of glutamate and glutamine synthesis in liver failure, and thereby utilizing the alpha ketoglutarate level and decreasing the protein synthesis. If we supplement the branch chain amino acids, then they increases the level of alpha ketoglutarate and improves the sarcopenia and protein synthesis. Endotoxinemia in the form of increased inflammatory mediators by level of IL-6 or TNF alpha, they suppress the protein synthesis and leading to sarcopenia. There is a tumor TNF alpha also promotes the transcription, promotes activation of nuclear factor and muscle ring finger motif that leads to decreased protein synthesis. So coming to sarcopenic obesity, only loss of muscle mass doesn't cause sarcopenia. There is a gain of fat in the muscles that is called sarcopenic obesity, also causes mortality. And the risk in sarcopenic obesity, the risk of metabolic and cardiovascular disease is more. There is a liver failure, mobility disability, frailty, increased healthcare cost, and all-cause mortality. These are the studies which all shows that sarcopenic obesity are associated with higher mortality. So how does sarcopenic obesity causes higher mortality, and how does obesity causes sarcopenia? So there is a interplay of three organs: adipose tissue, liver, and muscles. So in case of obesity, there is an increased leptin hormone, decreased adiponectin, and pro-inflammatory cytokines. And in liver also there is an increase in pro-inflammatory cytokine, disturb carbohydrate metabolism, and decrease insulin signaling. There is a failure of urea cycle and fibrogenesis in hepatic stellate cells. These all leads to insulin resistance and inflammation and leptin resistance. And this leads to intermuscle protein breakdown and impaired muscle glucose uptake. These all leading to release of aromatic amino acids and increased utilization of branched-chain amino acids. Increased utilization of branched-chain amino acids leads to increased muscle catabolism, and aromatic amino acid in blood leads to hyperammonemia, and hyperammonemia leads to increased myostatin expression and muscle autophagy, and they leads to depletion of muscle mass, strength, and thereby sarcopenia. These are studies on myostasis affect myosteatosis, that is basically fat accumulation in the muscle, affecting overall survival and mortality in patients of cirrhosis. These all studies showed that patients with sarcopenic obesity had worse median survival. They were older, and multivariate analysis also showed they had more liver failure. So sarcopenia, whether there is a role of angiotensin II also. So angiotensin II induces skeletal muscle atrophy by activating transcription factor EB, and thereby causing the muscle ring finger motif expression, and it leads to decreased angiotensin level. So angiotensin receptor blocker improves the muscle mass and also the sarcopenia. So this study showed this combination of losartan, which suppresses the angiotensin receptors, with branched-chain amino acid, suppresses the inflammation and liver fibrosis and sarcopenia. There is also intramuscular myostatin and pro-inflammatory cytokine pathway are suppressed by the losartan and branched-chain amino acid. So supplementation of branched-chain amino acid with angiotensin receptor blocker improves the skeletal muscle mass. There is no human study, only rat studies are there on angiotensin II. This another pictorial diagram which showed that those patients with receiving angiotensin II blocker with branched-chain amino acids, there is a synthesis of protein more as compared to degradation as compared to the patients who did not receive branched-chain amino acid and only angiotensin II. So whether Cystatin C and sarcopenia predicts mortality, as creatinine has some fallacies in predicting the AKI, and it gets affected with the muscle mass. So and the protein intake also. So Cystatin C was considered whether it along with sarcopenia can predict the mortality, and they included 180 patients, and they showed the cystatin level more than 1.5 and sarcopenia and mild sodium were independent predictor of ACLF and acute decomposition of liver failure in waitlist in patient waiting for the transplant. And the cumulative incidence of ACLF and mortality at 12 months were 50%, 34% in patients with sarcopenia and cystatin level of more than 1.5. This diagram also shows that a patient with sarcopenia and cystatin level 1.5, and they had higher chances of mortality, and those patients and also the higher risk of acute and chronic liver failure on waitlist mortality. So cause of sarcopenia in post-liver transplant. So apart from hepatocellular dysfunction and portosystemic shunting, which causes sarcopenia, liver transplant usually reverses the sarcopenia, but it can persist after transplant, as the patient can have collaterals which can cause the persistent raised ammonia. There are medication like tacrolimus and mTOR inhibitor. As mTOR inhibitor helpful in protein synthesis, the mTOR inhibitor decreases the protein synthesis. mTOR level is synthesized. mTOR stimulates the protein synthesis. Recurrent infection can also decrease the survival and increases the sarcopenia in post-liver transplant. Recurrent disease like recurrence of autoimmune liver diseases in post-transplant, it worsens the survival and sarcopenia. Lifestyle changes, renal failure also increases the cytokines and inflammation and decreases the mortality. These are the studies which have assessed body composition after liver transplantation, and they were all longitudinal studies, and they have done by DEXA and muscle stimulation and bioelectrical impedance, and they all had shown that there is a reduction in muscle mass, loss of lean muscle mass, and as in post-transplant patients. In post-transplant, there is an ongoing study in Japan. This comparative study of the effect of neuromuscular electrical stimulation and oral administration of branchin amino acid on preventing sarcopenia in patients after LDLT. It is still ongoing study, not published, and they have done that neuromuscular electrical stimulation they have done neuromuscular electrical stimulation along with branchin amino acid and during hospital stay daily, and thereafter every 14th day till 3 months, and they found that patients were improving, and they had more muscle mass, appendicular mass and lean mass as compared to patient who did not receive neuromuscular stimulation. So as the pathogen. Yes, ma'am. Branchin amino acids, those patients who has branchin amino acid along with neuromuscular stimulation, electrical stimulation, yes. So according to pathogenesis, the treatment includes, as the dietary intake is decreased, so we have to improve the nutritional intake, and we have to start the ammonia lowering therapies, testosterone supplementation, follistatin, which is a myostatin antagonist, branchin amino acid supplementation, decrease period of fasting, as the fasting causes gluconeogenesis and leading to utilization of the essential amino acids. We have to prevent and treat infection, optimize the management of cirrhosis complication, withdrawal of alcohol and other pathogens, improve physical activity, and mitochondrial targeted antioxidants like glutathione. In nutrition management, calories is the first choice. We can measure it by indirect calorimetry, or by we can start with the 35 kilocalories in non-obese and obese. We can restrict the diet. We can start with a protein of 1.2 to 1.5 gram per kg, and in critically ill patients we can increase the protein intake up to 2 gram. And we have to add the snacks timings and the breakfast also, and in the night also snacks should be indicated. Branchin amino acid supplementation is essential, and exercises in the form of frequency, intensity, time and type is also important in these patients. And in ILBS there is a study with the similar to the survival. The sarcopenia is the independent predictor of mortality in critically ill patients with cirrhosis. It was an observational study, and critical ill cirrhotic patients were admitted in ICU, and they had done CT scan within 3 months, and CT images was assessed at L3 level, and sarcopenia was defined if skeletal muscle index was less than 15 males and less than 39 in females. And they found that sepsis sarcopenia and Apache-2 scores were independently associated with mortality in cirrhotic patients as compared to the rest of the parameters. So future direction, we have to identify normal values of muscle mass and function across all the demographic areas and disease severity. Explore the mediators of liver muscle access to sarcopenia and decompensated cirrhosis and ACLF, and new therapies have to be included, including antioxidant, mTOR inhibitors, mTOR activators, myostatin agonist, and mitochondrial protective agents to help the electron transport chain. Thank you.